Good afternoon, everybody. Happy Wednesday. This is Ed Crow. Appreciate everybody coming on today. We've got 12:59. I'll just ramble on here for another minute or so just to give more people time to come on. We had actually quite a few register for the webinar today, so I will get us started here in just a minute. A couple things, I guess, house cleaning items before we get started. So we do webinars every Wednesday and Thursday at 1 o'clock, usually on Medicare topics, sometimes different things. In those who haven't been on before, our webinars almost always run 15 to 20 minutes. I've always tried to keep them fairly short. So, you know, I try not to have them run on too long, in fact. Looks like we're having audio problems. So hopefully everybody can hear me. Looks like we might be having some audio issues. I'm going to... Okay, so hopefully everybody can hear me now. I apologize for the audio issues. Of course, that happens as soon as we get started. All right, so let's get started here. So as I was saying, usually we do these webinars on every Wednesday and Thursday at 1 o'clock. They usually run 15 to 20 minutes. Today is going to be longer because it's a lot of content. We're going over the basics of Medicare today. So basics of A and B, basics of selling Advantage and Supplement, and then we're going to sprinkle some details in there as well for those of you who, you know, maybe are more familiar with this content. But in general, this is going to be a fairly basic 101 of Medicare sales, focusing on Medicare benefits, enrollment periods, that kind of thing. So I will record this. I do send out the recording to everyone that registers. So for future reference, if you want to watch one of our webinars but can't make the time, just simply register and you'll get the recording. The other thing I would say is if you have any questions, please send them into the webinar and I will answer them at the end. Okay, so again, usually these webinars run 15, 20 minutes. I always keep them there, but this one's going to take longer than that, probably about 35 or 40, I would guess, and a little longer now that I had audio issues. So having said that, let's get started. All right, so we're going to talk about A and B enrollment rules, A and B benefits. We'll hit supplements, Part D, and Advantage to an extent, and we'll talk about enrollment periods as well. And again, this is for people that are relatively new to Medicare sales. Hopefully this will give you a better idea. So we'll start with Medicare A and B enrollment. So and again, just some basics here. So people are entitled to Medicare A and B the first of the month they turn 65. So I get that a lot. So if somebody's birthday is on July 15th, their Medicare starts July 1st. So it's always the first of the month they turn 65. The one exception to that to be aware of is if somebody's birthday falls on the first of the month. Now you would think if somebody's birthday is on July 1st, they can enroll in Medicare A and B July 1st, but that is actually not the case. If their birthday falls on the first of the month, they can enroll the first of the month before. So somebody who has a birthday on July 1st would be a June 1 enrollment for Medicare. And I think it's safe to say that everybody probably realizes you're eligible for Medicare the first of the month you turn 65, whatever month you're turning 65 in. For those who are disabled, the rule there is you must be on disability and getting payments for at least 24 months to be eligible for A and B. So you could get somebody who's 40 years old who's on Medicare. That's because they were disabled by the state's definition, or by Social Security's rather, I should say, and they've been drawing payments for 24 months. Once they've drawn payments for 24 months, they're automatically going to get enrolled in A and B. And when you get that situation, that person certainly is eligible for an Advantage plan, for example, even if they're just, say, 40 years old. Eligible for A and B, they get auto-enrolled in A and B due to disability. You can put them in an Advantage plan. Supplements are a little more tricky. A person under the age of 65, and you got to watch this. I've gotten caught on this a bunch of times, not paying attention. If somebody's on Medicare under the age of 65, there's only certain supplements they can get. Traditionally, that was A, B, and C. Now it is A, B, and G in most cases. But they're not eligible for everything. So they can't get like a Plan N. They can't get a high deductible G, that kind of thing. To qualify for Medicare, you can either qualify on your own by working at least 10 years on the books, or you can qualify through a working spouse. So if you were married and your spouse worked at least 10 years, then you would qualify through them for Medicare A and B. So either way would work. Also, one thing, and I do get asked this once in a while, you have to be a U.S. citizen or a permanent legal resident in order to be eligible for Medicare. All right, and again, if we have questions, just send them into the webinar, and I will answer them at the end. So with Medicare A and B enrollment, so somebody's turning 65 July 15th, not everybody's going to be automatically enrolled in A and B. So the rule is if you're drawing Social Security payments at the time you turn 65, then you're automatically going to get A and B. You don't have to do anything. The card's just going to show up. So drawing Social Security payments, no problem. They're automatically going to get A and B. The standard Part B premium is $148.50. So that's what everybody's going to pay for Part B of Medicare. Keep in mind you have IRMA, which stands for Income-Related Monthly Adjustment Amount. For those making over certain amounts of income, and I'm going to show you an IRMA grid in a few minutes, for those making over certain amounts of income, they will pay more for Part B, and in some cases substantially more. But the thing to remember for IRMA is it's always 2 years earlier. So 2021 IRMA is being determined by what people made in 2019, for example. Next year for 2022, it'll go by 2020 income and so on and so forth. Always 2 years behind. The question I get a lot is why do they do that? Well, they try to give more time for people to have completed a tax return, so that's why they have the delay. But IRMA is applicable to Part B, and also it's the same income thresholds for Part D, so you can't forget that. If somebody has a B IRMA penalty, they're going to have, and we're not supposed to call it penalty. If somebody has a B IRMA, they're also going to have a D IRMA, and I'm going to show you the grid for both of them. So what if you get somebody who turns 65 and they're not taking Social Security payments yet? Well, they're not going to be automatically enrolled in Medicare. So you have to have them enroll online. In the past, we'd say have them enroll through the local Social Security office, but a lot of those aren't open. Depends on the state you're in, but a lot of Social Security offices are not operating right now, so it's really pushed heavily now to the online, and quite frankly, the online's pretty easy. So that's the way to go. I gave you the link there. It is basically ssa.gov/benefits/Medicare. And when they go on there, it's from the Social Security website. So sometimes people will get confused and think you're having them apply for Social Security payments. They certainly can apply to start drawing Social Security payments through there, but they can apply for Medicare only. So just let them know, well, Social Security handles Medicare enrollment and Social Security income payments. So you can go on there and click the Apply for Medicare Only button. That question will come up quite often. All right, so we got the two scenarios. Somebody turns 65, they're drawing Social Security, they're automatically enrolled in A and B. They turn 65, they're not drawing Social Security, they got to apply for A and B online. What about people who are working? Well, if somebody's working, there's a few rules there. They don't necessarily need A and B if they're working. So the rule is if you're working, actively working and getting coverage through work, in most cases you can delay your B enrollment because you pay for B. So if you're working and getting coverage through work and you want to keep your work coverage, it's up to you. But if you want, you can delay B, not pay for it, and just use your work coverage. But let's say that person is, so anyway, to go back for a minute, the two ways they can waive B is if they're working and getting coverage through work, or if they're getting coverage through an employed spouse. Well, what if that person stops working, or they stop getting coverage through work and they're 67 years old and they want Part B now? Well, that B enrollment, that's called the delayed Part B enrollment, and that is done online. And you do it through the same site I just showed you earlier, and that's how you enroll for delayed Part B. You need what's called an employment verification form to do that. So we'll just hit the rules for a minute, or kind of how that works. If you're 67, let's say, and in July your work benefits are going to end, or you're retiring in July, you need to enroll in Part B. You do it online. Medicare is not going to just let you enroll because you want to. You need a reason to enroll in Part B. And that employment verification form, which comes from your employer, is a form that says, yeah, Ed has been working since he's been 65. He's been getting coverage through us, or Same thing would apply if you're getting it through a spouse. And here's the form that proves that. So when I try to enroll in Part B online, I've got that employment verification form to prove that I've been working and getting coverage either through my spouse or myself, and I have a special election then to enroll in Part B. So to waive Part B, that question comes up a lot. To waive Part B, you got to be doing both things, actively working and getting coverage through work or getting coverage through a working spouse. People will fall victim a lot of times to maybe they are working, they're 68 years old, and they decide to retire, and their employer says, you know what, Ed, don't worry about it. You've been a great employee. We know you're retiring, so you won't be actively working, but we're going to leave you on the group benefits for the rest of the year. So I don't apply for Part B because I think, well, if I'm getting group benefits, I don't need B. Well, that's where I'm wrong. It's only a valid waiver for B if you're doing both things, working and getting coverage through work or coverage through a working spouse. So when I retire, I need to sign up for Part B. As I mentioned, it's easy to miss your Part B election period for that exact reason. So what happens if somebody makes that mistake? They're actively working, coverage through work or through a spouse. They don't think they need B, so they don't sign up for it when they retire or their spouse retires. Then someday their work coverage ends, and they say, well, I need Part B. Well, if they don't have a special election, the only time then they can enroll in Part B is January 1 through March 31st for a July 1 effective. So that's the Part B general election period. So think this out for a minute. If somebody was working, they retired, they stayed on their work coverage for another, for most of the year, and then in November, their work says, well, we're going to take you off the coverage now, and they say to themselves, well, I better apply for B. They can't. They have to wait and apply through the general enrollment period, January through March, and it's not going to kick in to July 1. So they won't have B until July 1, and they're going to have a Part B late enrollment penalty as well. So it's really important to know those rules. And again, I see we have questions. I will certainly answer those for you when we get done at the end here. But feel free to send them in, please. Talk about groups of 20 or more for a minute. So in the past, if somebody was actively working and getting coverage through work, we would always just say to them, don't worry, you don't need B yet. It's not always the case now. So if you're with a group of 20 or more, that is still the case. Working, coverage through work, your group's 20 employees or more, go ahead and waive B. But what if you're working for an employer of less than 20 employees? Well, in the past, same thing. We wouldn't make them get B. But the reality is when you're with a group less than 20 employees, Medicare is primary. So they're paying the claims, 80% of them anyway. The insurance companies in the past just used to pay anyway. They didn't care. So if I'm working for a group of 10 employees, getting coverage through work, I ignore getting Part B, I don't bother. The insurance companies would just cover my claims like normal. Well, they're not doing that anymore, so you got to be careful. So a group of less than 20, persons actively working, getting coverage through work, they still need to apply for Medicare A and B. If they don't, there's a good chance the insurance company is going to at some point say to them, hey, you should have been on Medicare because Medicare should be primary for you with this small group. And because you didn't, we're not paying 80% of your claim that Medicare should have paid. So group less than 20 now, even if once they hit 65, even if they're working, getting coverage, make them enroll in A and B. Or you should suggest that they do anyway. Okay, obviously the Medicare cost share changed for 2021. The standard Part B premium now is $148.50 a month. The deductible for Part B is $203. It's a one-time annual deductible. We're going to go over, I mentioned IRMA before. That's the extra amount you'd pay for Part B and D. The income brackets are adjusted every year. We're going to go over those, and keep in mind when they look at IRMA, it's based on what you made 2 years previously. If you get the scenario of a client who was making, say in 2019, they're making $300,000, but when they retire in 2021, they're going to make $40,000. Social Security is going to base it on their 2019 income, so they'll be paying an IRMA. You can appeal that. They have what's called a life-changing event. That means they retired, they had reduced or lost employment as a result, their income went down, they can call Social Security appeal and appeal to have the IRMA adjusted for what they make now. So that's really important to remember. I'm going to take a look at an IRMA bracket for you here. So this is the Part B IRMA. And as you can see, as we discussed, it's showing if you're an individual, the amount of income. So anybody individual making $88,000 or less, they pay the standard $148.50. If you're married, they're going to look at your joint income, and it's $176 or less. And as you can see, the more you made 2 years previously, the more it will increase your Part B premium under IRMA. So a couple making between $276,000 and $330,000, instead of paying $148.50, they're going to pay $386.10, and that's each. So that's IRMA, and this will adjust every year, but always 2 years behind. So if they have a special circumstance, life-changing event, and their income's gone way down, it makes tons of sense for them to appeal. And the IRMA tops out now at $504.90 per person for the highest income earners. That's for Part B. This is for Part D, so there's also a D IRMA. And as you can see, the income brackets are exactly the same. The amount you pay, though, is less, obviously. The IRMA is higher for B than it is for D. And the way this works is somebody's got a drug plan, and they're paying $10 a month for their drug plan, but they're fall into one of these income brackets. They're going to pay that additional money is a Part D IRMA. People often ask, well, what if somebody has a zero premium advantage plan? Well, you enroll them in a zero premium advantage plan. Let's say it's an individual and he's not married or she's not married. They make less than $88,000. It's going to stay zero premium. But let's say if that person in 2019 made between $138,000 and $165,000, well, their advantage plan isn't going to be zero. They're going to get billed $51.20 by the insurance company. It's billed through the carrier for advantage or Part D. And they're going to pay an extra $51.20 as a Part D IRMA. So it can make a liar out of you when you tell people they're going to have a zero premium advantage, but if they have an IRMA penalty, they're going to pay that penalty amount, and it's going to be billed through the plan. Part B doesn't work like that. B will be billed by Social Security, but D will go through the insurance carrier. I'm going to send this recording out, so certainly this will have the grids on it when you look at the recording. Okay, we'll talk about original Medicare. I wrote original Medicare cost share 2020. I do realize it's 2021, so they should say 2021. I guess I was caught in time warp there for a minute when I made this. So the hospital Part A deductible is $1,484. So keep in mind that's per admission with the 60-day benefit period. So what that means is if you're on Medicare Part A, when you go to the hospital, you're admitted, you're going to have a deductible of $1,484. Let's say you're admitted for 3 days, you pay $1,484 and you come out. Well, if you go back in within the 60-day benefit period, you won't pay another deductible. But if you go in the hospital, come out, and you're out for more than 60 days and go back in, then you'll pay a new $1,484. So you get basically a 60-day grace period. People don't stay in the hospital as long as they used to, but on original Medicare Part A, there is coinsurance. So as you can see, if you're in days 61 to 90, it's an extra $371 a day. If you're in more than that, which I haven't had one of those in a long time, but if you are, then you hit your lifetime reserve days. You get 60 of them, and you'd pay $742 a day on your lifetime reserve days. Keep in mind, too, I wrote up top, different than an advantage plan. So as I mentioned, in the hospital Part A deductible, it's $1,484 per benefit period. So you go back in 30 days later, you're good. You don't pay anymore. Advantage doesn't work that way. So if your advantage plan is $400 a day for hospitalization for, say, 5 days, you go in for 10 days, you pay your 400 times 5, and then 20 days later, you go back in the hospital, you're paying 400 times 5 again. Advantage plans don't have the 60-day grace period like original Medicare. Skilled nursing falls under Medicare Part A. In skilled nursing, when you're in the nursing home, the first 20 days are covered in full. After that, days 21 through 100, you're going to pay $185.50 a day. That's what the Medicare beneficiary pays. And people ask, what about after day 100? That's why you need, for example, a long-term care plan. Medicare or Advantage plans will not cover skilled nursing after 100 days. And quite frankly, what they will do, especially Advantage plans, if you're in a skilled nursing facility and you're not showing improvement, they won't let you stay in there for 100 days. They'll kick you out well before that, because the rule is if you're not showing improvement, then you don't qualify really for skilled nursing care anymore. And they will call you out on that pretty quickly, especially the Advantage plans. Original Medicare will now too, but the Advantage plans are much more strict about it. Okay, Medicare Part B. So as we all know, A is hospital and skilled nursing. B is basically everything else medical, so doctors, testing, lab work, anything out on an outpatient basis, outpatient surgeries. So Medicare Part B for 2021 will have an annual deductible of $203. The deductible does not repeat. So once you pay your $203 deductible, whether that was via a supplement G or N, you only pay it once. So if somebody's in supplement G, they meet their $203 deductible under Part B for the year, and then they move to a Plan N or an Advantage plan, there is no new deductible. You only meet it once. Trickier thing to think about is if somebody's on an Advantage plan, you just have copays. You don't have a deductible usually. But when they receive services, that internally deductible on the Advantage plan is being met, kind of under the radar. So if that person on the Advantage switches to a supplement, the deductible of $203 has already been met, assuming they've received some services on the Advantage plan. Okay, so on original Medicare Part B, $203 deductible, and then 80% coverage after that. And remember, when I say 80%, it's 80% of the Medicare allowable. So not 80% of what the doctor just feels like billing, 80% of what Medicare allows, which isn't a lot, believe it or not. I'll give you a quick example. MRIs on average are billed at like $2,200. Medicare allows about $480 for an MRI. So the 20% your client pays isn't near as much as you might think. All right, so there's Medicare A and B benefits. I brushed over them quickly just for the sake of time with the webinar. But again, in general, A is hospitalization and skilled nursing. Part B covers all other outpatient services for medical, including testing, things such as that. Obviously, A is a deductible, and then Part B is a $203 deductible, and then the 80/20. So if somebody wants a Medicare supplement, a couple things to keep in mind. Medicare supplements are secondary to original Medicare. So when somebody's on a supplement and they go to the doctor, the hospital, or anything medical, they're going to show them their Medicare card. The doctor or the hospital is going to bill Medicare. Once they bill Medicare, what's left over then will go to the supplement. So for example, Plan G doesn't cover the Part B deductible. So they're going to pay the first $203 of Part B services, and then the G is going to cover them in full. One thing to be careful not to get caught on is it's easy to say, well, on Plan G, once you pay your deductible, it covers everything. It doesn't really. It covers everything Medicare approves. So remember, supplements only cover what's approved by Medicare. So Medicare services that are approved, Medicare covers some of it. Supplement Plan G after the deductible will cover the rest. But if it's a service that Medicare won't approve, the supplement's not going to help either. So keep that in mind. So for example, supplements won't help with routine vision, additional annual physical tests and services, dental, basically anything that Medicare doesn't cover. So if you go to your doctor and you get your welcome to Medicare physical when you're 65, that's one thing. But let's say you do after you're 65, you don't get a full physical from Medicare, you only get a wellness exam. And basically, that's just to make sure you're still breathing. So say you're 68 years old, you're on original Medicare and a supplement, you go to your doctor and get a wellness exam. Doctor says, well, you know what, I want to run some other tests as part of your physical. Your client will probably get a bill in that situation because Medicare is not going to cover it and the supplement won't cover either. When you're on a supplement, also keep in mind there is no network. We get that a lot. I put somebody on AARP, which is United Healthcare, but I'm not sure their hospital takes it. There is no network on a supplement because remember, Medicare is primary, so the doctor and hospital are billing Medicare. They don't care whose supplement it is. It doesn't matter to them. It could be Eddie Crow's supplement. Not that I'm successful enough to have one of my own, but we'll pretend. But it doesn't matter who it is. They only care that Medicare is primary, so the company means nothing when it comes to access to services. And just for the record, every hospital in the United States currently participates with Original Medicare, and it's still like 97% of the doctors. So that's a big benefit of using a supplement is access to care. Obviously, Original Medicare is accepted countrywide, so it wouldn't matter what state you're in either, because the doctor or the hospital, they're just billing Medicare. They don't care who your supplement is. Supplement benefits are the same regardless of company. So, for example, if a Plan G is being offered, Plan G has set standardized benefits. Doesn't matter what company you look at. I hear a lot of people say, "Oh, I heard that Anthem is better than ARP," or I've never heard of Lumico, so I don't know if their benefits are as good. If it's a Plan G, the benefits are identical. The claims payment process is the same. Nothing is different. It is simply a pricing contest. That's it. One thing to note with supplements, the base benefits are all the same, but some of them will offer extra programs. Like, for example, ARP will have, or I'll use a different example, Anthem will have silver sneakers, pay for a gym membership. Aetna has silver sneakers on some of their supplements. AARP uses Renew Active. Renew Active is similar to silver sneakers, but just United Healthcare owns Renew Active, but it works the same way. Pretty much the same list of gyms. In some cases now, we've found that some YMCAs, which that was like silver sneakers staple, is that they had all the YMCAs. Some of them now, especially like in my area in Connecticut, some of the Ys take Renew Active, which is what AARP and United offer, and they don't take silver sneakers anymore. So something to keep in mind. Supplements don't provide drug coverage. When you have a Medicare supplement, you'd buy a standalone Part D plan if they want drug coverage. Do a quick review of our supplements. We'll get into some of the lesser sold ones too. I used to sell all of them basically. And there's a situation kind of for all of them. But Plan F was the Cadillac, obviously. Plan F's 100% coverage. There is no deductible. If Medicare approves it, Plan F covers it medically. So as a covered in full plan, anyone who's aging into Medicare, becoming Medicare eligible after January 1st, 2020, they can't buy a Plan F or C anymore. So F is grandfathered for the people that had it previously, or if somebody aged into Medicare, or were eligible for Medicare prior to 1/1/20 and they want to move to an F now, they can. It's still available to them. But anybody who was Medicare eligible as of 1/1/20 or later cannot get Plan F. So the Cadillac would be G. G is very similar to F. A Plan G supplement simply says, we're just like Plan F, except for we don't cover the Part B deductible. So on a Plan G, person would pay their annual $203 Part B deductible, and then G covers in full just like a Plan F does. Plan N is probably the most popular supplement that I've seen, or that we see out there that sells. And really, Plan N's pretty easy. I mean, it's very similar to a G. N has a 203, doesn't cover the 203 Part B deductible, just like G. The only other difference is, though, on a G, once you pay your 203 Part B deductible, you're covered. On an N, once you pay your 203 Part B deductible, you're covered, except for a primary or specialist doctor can bill you up to $20. It's not necessarily a copay. It's capped at $20. So sometimes they'll get billed less, maybe $14, $15, but never more than $20. And you pay $50 for the emergency room. So that's the big difference between Plan N and G. So really what it comes down to with N and G is, let's say there's a $40 premium difference between N and G. Well, the only real difference there is the $20 for a doctor's visit. So if your client's going to the doctor less than twice a month, N might make some sense for them. Plan G does cover Part B excess, N doesn't. So that comes up often. N doesn't cover Part B excess. Should I put somebody in that? Well, the thing to keep in mind is Part B excess is not billed that often. So not every doctor can bill excess. And there's some states where they can bill hardly any excess at all. But nonetheless, the only doctor that's allowed to bill excess charges are doctors that are in the Medicare program but not accepting assignment, and that's not many doctors. So your standard doctor participating with Medicare, they can't they can't charge Part B access anyway, so that benefit really doesn't matter. It's just for those that are in Medicare but not accepting assignment, which is a small list. It really is. And when a doctor can charge excess, it's capped at 15% additional of the original Medicare allowable amount. So it's not 15% whatever they charge, it's 15% of what Medicare allows. Okay, supplements you don't see sold as much, but they're good plans. In a minute I'll tell you why they don't get sold quite as much, but Plan K, for example, Plan K is usually very inexpensive. Like in a lot of states, for example, AARP offers a Plan K for like $60 a month, so it's a great deal. It covers 50% of what Medicare doesn't. So if you think about it, Part B covers 80%. Plan K will cover half of what isn't covered, so 10%, leaving your client paying 10, and the supplement will pay 10. Same thing with the hospital deductible. It'll cover 50% of what Medicare doesn't. So the $1,400 hospital deductible, Plan K will cover half of it. And you'd be surprised. Medicare doesn't allow a lot, so these amounts won't add up to much. And with Plan K covering half of it, people on Plan K are usually pretty happy. If their cost share on Plan K ever added up to $6,200 to $6,220, that'd be their out-of-pocket max, and then Plan K would cover them in full, just like a Plan F or G after that. But I don't think I've ever had somebody get to to even to $5,000 for that matter on a Plan K. Plan L works just like K, except for it covers 70% of what Medicare doesn't cover. So 75% of the hospital Part A deductible, 75% of the Part B cost share. So for example, 20% will cover 75% of it. Your client pays 5%. Very small amounts, very small. The out-of-pocket max on a Plan L is $3,110 for 2021. And then high deductible F and G. I should have put G on there too, because remember, Plan F is only available to people who were eligible for Medicare prior to 1/1/2020. High G works basically the same. What these plans say is, you go on our high deductible Plan F or G, you pay whatever the Medicare cost share is. We don't cover anything until you hit the out-of-pocket max, which on an F and G is $2,370 in 2021. So they pay the Medicare cost share. If they hit the $2,370, then they're covered in full for the rest of the year. Why would somebody want to do that? Well, because of the premium. It's incredibly low. People rarely hit the $2,370. In fact, they only hit that about 5% of the time. So a high deductible F or G can make a lot of sense. If you look at a company like United American, they specialize in high F and G plans. Their G premium in a lot of states is like $20, $25 a month. It's very low. So it's a very good deal for your client, if you can wrap their head around how it works. Because they're going to think often, oh, it's a $2,370 deductible, but it isn't. You're paying just what Medicare doesn't allow, or what Medicare doesn't cover, and if that adds up to $2,370, so it's really shouldn't be called high deductible. It should be called an out-of-pocket max. It's a $2,370 out-of-pocket max, kind of like an old 80/20 plan with a $2,370 out-of-pocket max, $2,370 rather. Anyway, if you have more questions about that, call us or email us. I used to sell a ton of high F and G, so I know those plans very well. The problem with KL and high F or G is the commissions are very low. Because if you think about it, the premium's really low, so the commission's really low. So you don't see it sold as much. I'll do a separate module or webinar just on this, but I basically would sell it when that was the only way a sale was going to occur. For example, they had the lowest cost Plan N. Well, then I'd brush off the KL or high deductible F or G. Anyway, I'll do a module on that at some point. Module webinar. As I mentioned earlier, I won't run through this whole thing again. No Plan CF or high F sales for anyone that turned 65, for anyone that was eligible for Medicare prior to 1/1/20. So anybody eligible for Medicare prior to 1/1/20, they can get CF or high F. Anybody that was eligible for Medicare 1/1/20 or later cannot get it. But again, you got somebody who's 70 years old, they've been on Medicare for a bunch of years, they want an F or a high F, they can get it because they were eligible for Medicare prior to 1/1/20. Talk about guaranteed issue for a minute. So supplements, as you know, in most states are underwritten. They're subject to underwriting, but not always. So if you're going to write somebody a med sup, they have guaranteed issue for a couple situations. So when you're first eligible for Medicare, supplements are guaranteed issue, so they cannot be underwritten regardless of the state you're in. If somebody's losing employer coverage, and let's say they had Medicare A only, and they're signing up for B, it's guaranteed issue. They're losing employer coverage for the first time, it's guaranteed issue. And if they're moving from another state, so they move from a state where they had a supplement, that supplement is not available in their new state, that can be a guaranteed issue situation as well. Supplements are never underwritten under any circumstances in the 4 states that don't allow underwriting at any time, and those are New York, Connecticut, Mass, and Maine. So in those states, at any age, at any time, people can switch supplements and they're never subject to underwriting. Those are guaranteed issue at all time med sup states. All the other states do have situations where people are underwritten. Okay, so in a guaranteed issue state, for example, let's say somebody's in a Plan G and they want to move to a Plan N or a Plan G with another company or within the same company. In a guaranteed issue state, they can make that change the first of any month all year. They can do that in a non-guaranteed issue state as well. However, in a non-guaranteed issue state, so any state other than Connecticut or New York, Connecticut, Mass, and Maine, if they want to make that change, they can first of any month, but they'll be subject to underwriting. And it's going to be simplified underwriting, kind of similar to a final expense plan. So you live in Maryland, want to switch from, you're on a Plan G with ARP, you want to switch to Medico because they're cheaper, you can. You can do it first of any month. You got to pass underwriting because Maryland is a state that allows underwriting. There are some states that have the birthday rule. Birthday rule is a 30 or sometimes 60-day window every year surrounding your birthday where you can change on a guaranteed issue basis. I think off the top of my head, birthday rule states that I know right off the top of my head are California and Oregon. There might be another one I'm forgetting. But there are a couple of states that have the birthday rule. I think California is a 60-day window now, but when 60 days surrounding your birthday, you can make a change on a guaranteed issue basis and avoid underwriting. If you want to check supplements, because as I mentioned, it's just a pricing contest, you can do that on our quote tool. So on the Pinnacle website, pfsinsurance.com, we have a quote engine that's available to anybody that works with us. Even if you only have one carrier with us, you can quote it, and it'll quote and compare all plans, price everything out. You can make comparisons. It's very easy to use. You will need a username and password to get into it. And it will also quote all lines of business, whether you have those companies or not, and whether you have them with us or not. So it'll do Med Sup, Med Advantage, Part D, Final Expense, which is really slick and easy to use, Term and UL, annuities. The annuity engine's awesome. Long-term care. So it'll quote and compare everything for you with all the companies from one spot. If you need a username and password, as long as you got at least a contract with us, at least one carrier with us, just call us and we can provide that to you. Okay, talk about Part D plans. Some basic stuff here. Standalone Part D plans, you can purchase standalone Part D for somebody who's on original Medicare only and they just want a Part D, or somebody with original Medicare a supplement in Part D. One misconception is people think you got to have A and B to get a drug plan. You don't. You only need to have Medicare Part A. You don't have to be enrolled in B to get a drug plan. I've actually run into this problem before where I get somebody who is, I don't know, they're 67 years old. They've had nothing. They've had Medicare A only. They enroll in Part B and not thinking about it. I've said, oh, that's a special election for a drug plan. So I put it in an app. It isn't, because you don't need Part B to get a drug plan, so it's not a special election. You could have bought a drug plan when you had A. There are a number of companies that offer Part D plans. I get a lot of people who say, well, which one's the best? There is no such thing. It all depends on the pharmacy you go to and the medications you take. That's really what it comes down to. Some companies cover certain drugs really well, not others well, so there isn't a best Part D drug plan. To find the best plan for somebody, you really have to run it. You got to run it based on the drugs they take and see which plan will come out the best overall. It's easy to do, but it's really almost impossible just to eyeball it now. So the other thing is, if somebody has a supplement with ARP, for example, you don't need a drug plan with ARP. You can use any company you want, whatever company comes out the best for them. Part D drug plan benefits are certainly very different from company to company, and the formularies and the way they cover the drugs and the level they cover the drugs are really different from company to company. So really you need to run those on one of our tools if you want to see which drug plan is going to come out the best for your client. So you can run them on either Connect for Medicare or Sunfire. If you're not familiar with those platforms, we offer both to all agents that work with us at no cost. Both of them are online enrollment portals, but they'll also quote, compare, they'll save drug lists, save doctor lists, and then you can do online enrollment for Advantage, Part D, and Supplement through them. And they do also operate as a simple, kind of basic CRM to save all the information. So run drug plans through Connecture or Sunfire. Doesn't cost you anything to use either one. And you can save the lists on there so you don't have to enter them every year. And it'll save your client's info too, and then you can enroll them either by text or email through that system with all companies. I made a note there. I forgot what I was talking about. Oh, I mentioned getting Part B is not a SEP for a standalone RX plan. So just don't fall prey to that. Okay, we'll talk about Medicare Advantage for a minute. So obviously, if you have original Medicare, a supplement is secondary to original Medicare, and a standalone drug plan. Advantage is completely different. So Medicare Advantage plans, the first thing to know and mention to people is it replaces original Medicare. So if somebody enrolls in an Advantage plan or Joe Namath plan, as we say a lot now, that Advantage plan, just like a group health plan, is going to become their primary insurance. Medicare is not secondary. They're not anything. They're not involved. The Advantage plan is the primary. When somebody takes a zero premium Advantage plan, they still pay their Part B premium. Make sure to mention that. And like I tell people who are looking at Advantage plans, it's very similar to a group or individual health plan. Pay copays for all the medical services. So whatever the Advantage plan says you pay, that's what you pay. It has nothing to do with the original Medicare benefits because the Advantage plan is replacing original Medicare. Your Part D drug benefit is included, and that Part D drug benefit's just as good is the standalone drug benefits. So people might think, well, you pay for the standalone plan, so they must be better. They aren't. In some cases, the Advantage plan, Part Ds, are better. And then Advantage plans, of course, give you additional benefits like vision, dental, full preventative, over-the-counter benefits. They give you things that original Medicare doesn't cover. And remember, if original Medicare doesn't cover it, the supplement won't either. So Advantage plans do come with some nice additional benefits that people can take advantage of. What are some of the negatives? Well, some of them are the Advantage plan has network, right? So, unlike original Medicare where you can go to any doctor that participates with Medicare, doesn't matter who the supplement is, on an Advantage plan, you've got to use an in-network doctor if it's an HMO. If it's a PPO, you can go out of network, but nobody's going to be happy when that happens because you're going to pay a lot more. So there's network to consider with an Advantage plan. There's a lot of PPOs out there now, so plans that have in-network and out-of-network benefits, although you pay a lot more out-of-network. But even the HMOs now, most of them don't have referrals anymore. So you don't need a referral from a primary to go to a specialist. The PPOs don't allow referrals anyway, so they won't have them. But a lot of the HMOs don't do referrals anymore either. Some still do, but a lot don't. The most popular Advantage plans certainly are zero premium. The zero premium Advantage plans have really taken control, and you see just less and less premium Advantage plans sold every year. Another popular one are Part B reimbursement plans. So for those not familiar, there are a number of plans in certain states where if you enroll in them, they will reduce your Part B premium for you. And when you run the benefits on Connecture or Sunfire or a quote engine, it'll tell you by how much. Like, for example, Ultimate has plans that lowers it by 130. MMM has plans that'll lower it by 144 a month. But usually on those Part B reimbursement plans, the people aren't paying as much or maybe nothing for their Part B premium, but the benefits usually aren't quite as good as the counterpart plans that don't pay for the Part B premium. So there's a give and take there, and you really always got to take a look at them. Advantage plans are always guaranteed issue. There's never any underwriting allowed on them. Now, out-of-pocket max. So just like a group or individual health plan, since you're paying copays for everything you do medically on an Advantage plan, they all have to have out-of-pocket maxes. The highest it can be in any state is $7,550. Remember, that's medical only. It has nothing to do with drugs. But that's the medical out-of-pocket max for copays, meaning on an Advantage plan, if somebody spends $75.50 in copays, they're done paying for the year. But keep in mind, some states have plans that are much lower than that. For example, California has counties with plans that the out-of-pocket max is $800 a year. In states like, New York, Connecticut, they tend to be higher, $6,700 or sometimes $7,550. But in some states, the out-of-pocket max can be incredibly low. We always get a few of these. With a Medicare Advantage plan, you cannot add a standalone PDP. So the idea makes sense logically. Well, if I put somebody in an MA-only plan, a Medicare Advantage without prescription drugs, then I can give my client a standalone PDP. You cannot. So an MA-only plan cannot have a PDP alongside of it. All Advantage plans have to cover emergencies and urgent care worldwide and or out of network. So if you're using a plan out of North Carolina and your client says, yeah, but this plan just has a network in North Carolina, I like to travel a lot. Well, they're always going to be covered no matter where they are for emergencies and urgent care. So that wouldn't be an issue. And all Advantage plans have to cover worldwide travel as well. All Advantage plans cover preventative services. One place where an Advantage plan is better than original Medicare and a supplement is with preventative. So you can, on an Advantage plan, get a full physical every year. Not just to check to see if you're breathing. You can get a full covered physical. Versus original Medicare and a supplement, you could run into issues there because after you're welcome to Medicare physical when you're first eligible, after that, it really doesn't allow for much to be done. And if Medicare doesn't cover it, the supplement won't either. So you don't have that problem with the Advantage plan. Some of these Advantage plans have regional or state networks. Some of them, though, have national networks. I mean, Aetna is one that comes to mind right away. Aetna's PPO platform, a lot of their PPOs are their full national network. Again, we get a lot of calls from people saying, well, what plans look good in this state, or, what plan's good here. You can run those with us. So you've got the quote and comparison site on the pfsinsurance.com website, so you can run and compare these plans there just using a zip code. Or you can also run and compare plans on Connect for Medicare, Connecture I call it, because that's the company, or Sunfire. You have access to all three of those at no cost with us. You would just need username and passwords. And you'd have to have a contract with us for at least a carrier. So we'll do strengths and weaknesses of Advantage plans. The reason I do that is when I would talk to clients, I would go over pros and cons. So I'd give them the strengths and weaknesses of the original Medicare supplement and drug plan. And then I'd go over the strengths and weaknesses of Advantage. So strengths of the Advantage, I already touched on most of this, but little to no monthly premium, drug benefits included, full preventative benefits, additional benefits that Joe pitches on television like vision, dental, OTC. Usually no deductibles and the copays are reasonable. And they usually have pretty good networks. I mean, some of them have really good networks and large national networks and out of the country coverage. Those are kind of the strengths of an Advantage plan. Weaknesses are you've got a network. Now, with a PPO, you can go out of network, but it's going to cost you a lot to do that. So it's a network nonetheless. And while the copays are reasonable, you have a really bad year, your copays could add up to your out-of-pocket max. Advantage plans are managed care plans. They're insurance company plans, so they're going to have prior auth requirements and managed care elements, hoops to jump through in some cases. Where on original Medicare with a supplement, you really wouldn't have to deal with that. And then Advantage Plan's benefits are subject to change in January, sometimes substantial change. So might necessitate the need for you to move somebody to a different plan if the Advantage Plan they're on has a really bad renewal and makes their benefits look terrible. You have to worry about that on a supplement because a Plan G is a Plan G and N is an N. The benefits don't change. Strengths and weaknesses for SUPs. Again, just a quick summary here, so no network to worry about. There's no prior author managed care element on a SUP. It's all original Medicare. Can determine the exact amount of coverage. Give somebody a Plan G and say after 203, annual deductible, you're done for the year. So you can determine the exact amount of coverage, or maybe you look at Plan N for them. Benefits don't change year over year, so supplements tend to stay on the books for a long time. They're very low maintenance. And then the other nice thing is, even though you got to pay for a drug plan, you can pick one specific to the drugs they take. Versus an Advantage Plan, it just comes with a built-in drug plan. With a supplement in a drug plan, you can tailor to the plan that fits specifically the best for that person's drug list that they have. Weaknesses, the main one on a supplement is 3 premiums. Part B, the sub premium, and the Part D premium. Some other kind of lesser to an extent important differences or weaknesses of a supplement are you don't get a full annual physical. Sometimes the doctors can deal with that, by the way. Your clients will say, I went for my physical, I'm 68, I'm on original Medicare and a SUP. Got a physical, but my doctor asked me if I was having trouble with my shoulder or something else. Because remember, diagnostic services are covered in full. So the doctor sometimes will look at some diagnostic issues at that appointment that will allow them to run the tests and stuff they want for the physical and still have it all covered in full because it's going to be billed as diagnostic, not as preventative. And supplements don't cover preventative vision. Now, they cover medical issues with the eye, cataract surgery, for example, but an eye exam they won't cover, and they don't cover dental. When you read in a summary of benefits, original Medicare covers dental, they don't. The details of that are the only time original Medicare and or a SUP for that matter would cover any dental is if it's damage done, structural damage done to your mouth in the course of an accident. So that's not knocking a tooth out. That's like if you're in a car accident and you need major surgery and the teeth happen to be part of it, then there can be coverage as a medical benefit with Medicare, but that's very rare. So question comes up a lot, which option's better? It depends is the answer. In general, people in good health will, a lot of times, who don't go to the doctor that much, they'll want to try an Advantage Plan. They really find the idea of no premium appealing. They've got all the preventative benefits. Obviously, the much lower monthly cost can generate huge savings for them, especially if they're not going to the doctor a lot. Sometimes the person just can't afford a supplement. And they'll go with an Advantage Plan just out of lack of the ability to pay for a supplement. Sometimes those, people in poor health often will go with a supplement because if they're doing tons of doctors and hospital visits, they're going to go with a supplement because then it's going to limit their out-of-pocket. They'd rather just pay a monthly amount and just know that they're not going to get crushed with copays. People that want access to a wide range of doctors and hospitals, a lot of times will go to a supplement because they can go pretty much where they want. And then sometimes there's people who like the idea of an Advantage Plan, but they don't want to deal with managed care, prior authorization, that kind of thing. So they'll go original Medicare and a supplement. But really, it depends on the person, quite honestly, to tell which one fits them best. On the AHIP and the various tests, it always says not to ask any medical questions. I mean, I don't ask specific ones, but I think to do your job well, you've got to ask a few things. They don't have to be specific, but you can just in general say, do you receive a lot of medical care? You don't have to give me details, but do you go into the doctor or the hospital a lot? Do you have any major medical conditions that require a lot of maintenance and doctor's visits? Again, you don't have to tell me what it is. I'm just in general. And then sometimes ask them, how do you feel about a network of doctors? Because once in a while somebody will say, oh, I don't want to deal with any networks. All right, well, that's probably a supplement client then. more and more in today's day and age, people are okay with the idea of Advantage, but those are some questions to ask to try to see what might be a better fit for them. All right, wrapping up here, going to the enrollment periods. So, as you know, somebody turning age 65, I think most of you probably know, they are eligible for an Advantage plan or a supplement 3 months before the month they turn 65, the month they turn 65, and 3 months after. So you meet somebody in June, and their birthday is in September. You can write them in June, and it'll kick in September 1st to coincide with when Medicare starts. Medicare Advantage plans will never, or drug plans for that matter, or supplements will never retro back. It's always going to be the first of the next month, except for if you're writing somebody 3 months before, it's going to kick in the month that their Medicare starts. During the AEP, you can make any change you want. So every year from October 15th to December 7th, that's an existing person's opportunity to make a plan change if they want. They can go from one Advantage to another. They can go from one supplement to another. You can change supplements anytime, though, or they could change drug plans. Remember, though, Advantage and drug plans are always guaranteed issue, but if you're in an underwritten state and it's AEP and the person says, geez, I had an Advantage plan, it was working great, but now I'm really sick and I got a ton going on. For AEP, I want to switch to a supplement. In the underwritten states, they're going to be subject to underwriting, and they're probably not going to be able to. Nonetheless, the opportunity to make a change every year, say they just want to switch to a different Advantage plan or a different drug plan, is from October 15th through December 7th for an effective date of January 1. While you can only take applications starting on the 15th, you can certainly see people and talk to them about 2022 benefits starting October 1st. And if you have a book of business, you should utilize those extra 15 days to talk to people. Just can't take an app then. And remember, changing supplements is subject to underwriting in underwritten states. The OEP. During the OEP, which runs January through March 1st, I should have said January 1st through March. During the OEP, somebody can make a couple different changes. They can switch from one Advantage plan to another, or they can go from an Advantage plan back to original Medicare, a supplement, and drug plan. Again, subject to underwriting on the supplement in underwritten states. But that's what they can do during OEP, and they can only make one change January through March, and it kicks in the first of the next month. So if I meet somebody during OEP, February 20th, they say, I hate this Advantage plan, I want to go to original Medicare, a supplement, and drug plan, or I hate this Advantage plan, I want to go to a different Advantage plan. I put in an OEP app for them. It'll kick in. I did it in February. It'll kick in for March 1st. Or if I meet them in March, it'll kick in for April 1st, but you can only make one change once during OEP. And also, you get the question, can I go from supplement, original Medicare supplement and drug plan during OEP to an Advantage? No, you can't. I mentioned before you can change supplements anytime you want. Medicare Advantage and PDP, once you get done with OEP from April through December, you can't change people without a special election. So once April hits, they got an Advantage plan. Unless they got a special election, they're in that Advantage or that PDP until next open enrollment. A couple special election periods to keep in mind. Obviously, you've got 5-star drug plans. If there's a 5-star drug plan in your state, that's a special election anytime. So 5-star drug plan or Advantage plan, I should say, people can switch to that plan the first of any month during the year at any time. You've got states that have drug help. So, for example, Medicare Savings Program, that creates a special election. If somebody moves out of the service area of one plan to another, that's a special election, and then you've got your trial right. So for those not aware, a trial right is if somebody's turning 65 and their first plan is an Advantage plan when they turn 65, they have a 1-year, 12-month trial right to move from that Advantage plan back to original Medicare, a supplement, and drug plan the first of any month for the first 12 months on a guaranteed issue basis. That's for everybody in every state. So you turn 65. When you turn 65, first plan's an Advantage plan, you got a 1-year trial right. The other trial right to keep in mind, and this one comes in really handy, is let's say it's somebody who's never been on anything but a supplement since they turned 65, and they want to try an Advantage for the first time. If it's their first time trying an Advantage plan, once they enroll in it, they then have a 12-month trial right, meaning at any time during the next 12 months, first of any month, they don't like that Advantage plan, they can switch out of it back to original Medicare, a supplement, and drug plan. It's a good way to get people to try an Advantage plan, get a sale for yourself as well. And if they don't like that Advantage plan, then you can rewrite them the supplement and drug plan, and you get paid on that too. So everybody wins in that scenario. But remember those two trial rights, they can come in really handy. I threw a compensation slide in there. So here's the set compensation. It's set, but for those not aware, it's set by CMS, by the government every year. This is the street comp. My agency, we never pay below street comp. And with us, you're paid direct by all the carriers. So we're not paying you the money. You're getting it direct by the insurance company, and you own the book of business. And those are the set comp levels, the max amount an individual can make per the government, so per CMS. If you forget these amounts, you can just search Medicare Advantage Commissions 2021, I think for the second or third result, and we've got that comp schedule up there. So as you can see, California and New Jersey, they're the highest for Advantage plans, 672 with a 336 renewal. Connecticut, PA, and DC is 607 initial compensation, 270 renewal. And then you can see the national comp grid, and that's every other state basically. 539 initial, 270 renewal. So that's the commission for Advantage plans set by CMS, and that's the 2021 level. Standalone drug plans are much lower, and they're the same in every state. $81 initial, $41 renewal every year. A couple final thoughts. That was a long webinar. Like I said, they usually won't go that long. Use the quote site. Use Connecture and Sunfire. Very important. Take advantage of our free Medicare lead and marketing program. That's 100% reimbursement for up to $500 a month. That's 100% reimbursement up to $500 a month to offset your cost for leads, marketing, advertising. As long as it's for Medicare, you can use it. After 6 months at 100%, up to $500 a month, it goes to 50% reimbursement, but still up to $500 paid to you. I'm going to do a webinar tomorrow on AHIP for those interested at 11 o'clock, or I'm sorry, at 1 o'clock tomorrow. I took the test on Monday, so I'm just going to go over that, give you some pointers. It's really not that bad this year. That's it. I'm going to check for questions. I'm going to send a recording of this out to everyone that registered, like we do every webinar we do. So future reference, you want to watch a webinar but can't make it, all you simply need to do is register and you'll get the recording. Let's see what we got for questions. And it looks like we have a fair amount of them. Okay, a lot of people saying they couldn't hear me. Yes, we lost our audio there. So that's unfortunate. Somebody asked, how do I buy Plan B? We went over that. You would buy Part B of Medicare online, or if you're drawing Social Security, you'd be automatically enrolled. Next question was, how does Plan A and B cover prescription drugs? It doesn't. Medicare A and B doesn't cover drugs. Do K or L have excess lifetime reserve days? No. Supplements K and L do not. Remember, a supplement only covers what's approved by Medicare. So once Medicare benefits end, the supplement benefits end. Okay. Somebody said you can have an MA with a PDP. Yeah, but that's just for a private fee-for-service plan. It's a good point, though. I was referring to regular Medicare Advantage plans, but yeah, I guess if you had a private fee-for-service plan, you could have a standalone drug plan with that. Although private fee-for-service plans, while they're still around, they're certainly not growing in popularity, so there's less and less of them every year. Can a Medicare recipient live overseas? Yes is the answer. They can. You can be overseas, and you're supposed to, when you're overseas, actually still keep Medicare A and B. Often people don't, which is a mistake, but yes. Another Medicare supplement weakness is underwriting. I did mention that. Some of these are just opinions. Let's see. Okay, somebody said I'm looking at choosing a Medigap policy, and I don't see anywhere that it is GI for MedSup if you move to another state. Yes, some companies are guaranteed to shoot MedSup if you move to another state. However, it's not commissionable, just so you're aware of that. So under 65, disabled on Medicare, never on MedSup or MAPD, only PDP, can they enroll? Yes. So if you got somebody under 65 and they're on Medicare, you can enroll them in an Advantage plan, but they got to have an election period. So it's got to be, during AEP, you could enroll them, or if they've got a special election. So somebody under 65 on Medicare, yes, you could put them in an MAPD plan. Okay, let's see. Okay, how does the transition work when a Medicare recipient had public aid pay for Medicare B? Can he get a Medicare Advantage? I would say call me on that. I'm not sure I'm following your question completely. Basically, if somebody's on Medicaid, they can still get an Advantage plan. So if they're on Medicaid or they're getting Medicare Savings Program like QMB, for example, and they're not paying their Part B premium, absolutely they can have an Advantage plan, and they could even have a dual plan in that situation. So yeah, but call for more details on that if you want. Medicare services can be provided by foreign doctors in foreign hospitals. No, not usually. Medicare does not cover, well, you need to keep Medicare while you're out of the country. Medicare doesn't cover out of the country. Some supplements do provide a benefit out of the country, however. Good question. Okay, last couple questions. It looks like that's it. Well, again, webinar went a lot longer than we normally do. It was a lot of content, though. I appreciate everybody joining me. Tomorrow, remember, I took AHIP on Monday. We'll go over, tomorrow at 1 o'clock, I'll go over AHIP. Just that invite was sent out, the same invitation as this one. It was just the second link to register. So if you want to hear that presentation will probably be that webinar will be about 15 minutes, 20 tops. Other than that, I appreciate everybody coming on today. Really do. A lot of good questions. Thank you. Hope this was helpful in some regard, and hopefully I'll see you on a future webinar. Thanks and have a great day.